So this is a really critical topic, I think, in healthcare. And uncertainty is an issue that I think is hard for all of us. I speak about this from my perspective as a patient and my perspective as a clinician. I'm a family medicine PA by training. And I think if there's any area where all of us would love to have 100% certainty, it's in any decision that we're making about how to be as healthy as possible. But that's just not how life works. So I think today we're going to hear some very innovative and interesting strategies. And toward that end, let's get started. So I'd like for you both to think about a moment, big or small, when uncertainty in medicine really came to life for you. Dmitri, would you like to go first?
Yeah, gladly. Really interesting question and really great to be here, Susan. So I'll take that question from the lens of an educator. In medicine and in health professions education more broadly, we're always moving through transitions. Medical school, residency, some of us fellowship, clinical practice, moving to different hospitals, working through something as disruptive as a pandemic, as I'm sure we'll hear a little bit later from my colleague. And there's uncertainty all around us as we kind of transition through those moments. And yet, even though it's always there, it rarely gets spoken about explicitly, right? There's this unspoken expectation that we just have to move through it without acknowledging it. So for me personally, there was an awakening back in 2017 while I was a faculty member in the Department of Emergency Medicine and precepting residents. And what I noticed, what I saw were residents discharging patients who had come in with a significant chief complaint for them. They took the initiative to come to the ED to get evaluated, and they've gone through a thorough emergency department workup. And oftentimes, they left without a clear diagnosis. We had no idea what was taking place within them to explain their symptoms. And what I would hear residents say was something like, knock, knock, great news, there's nothing wrong with you. And that sat with me, and I remember thinking, wow, how could clinicians be thinking that, saying that, framing their conversations in this way, especially in moments that are seriously very stressful for patients. And that really got our research team thinking about a specific type of uncertainty, and that's diagnostic uncertainty, and how do we make sense of it? And equally as important, how do we go about communicating it? And what came to life in those moments was the realization that there was essentially no formal training in any curriculum to prepare us as clinicians and as educators to teach, to navigate, to communicate, and problem solve in the midst of that uncertainty. And I think for me as an educator, that was a significant turning point.
That is an absolutely wonderful example. Speaking from my own experience as a patient, when they walk in and say good news, I'm like, oh boy, no, it's not. It's going to evolve, and I'm going to have to wait until everything reveals itself. So that is a wonderful example. So Lakshmi, what about you, your experience?
Yes, thank you so much, Susan. And thank you, Dmitri. Of course, we've been amazing collaborators on this journey together. And I want to echo and amplify everything Dmitri said. For me personally, I took a year during my pulmonary critical care fellowship medicine training to do a master's of arts in education to further my education research. I'm a medical educator. I love training the next generation of residents, fellows, and students how to be a better clinician, how to be a better doctor, how to be better with patients. And in my master's course, I took this course with chemistry teachers and science teachers, and I took this course with a climatology professor named Professor Michael Ranney. And the course was on problem solving. And I said, this is really relevant to me. This course is really interesting to me because there's so many complex diagnostic problems in medicine, and it's hard to kind of navigate them. And he said, what do you mean complex diagnostic problems? I've watched House. It seems like you get a diagnosis or you don't. You have kind of a brilliant doctor or you don't. What is the problem-solving nature of it that you speak of? And that sparked in me something that totally changed my entire kind of research focus. That I said, wow, it is not as black and white as the episodes of House MD show us. They're actually, just as you used that word, Susan, journey. diagnosis is often a process. It's often a journey. And we as clinicians have to help patients and families navigate that diagnostic journey and that process together while encountering the vast amount of uncertainty that we face in the ER, as Dmitri does, in the intensive care unit, or in the outpatient pulmonary clinic, as I do, and everywhere in between. And so that really spurred my entire research focus to say, hey, I want to help with how do we teach about diagnostic uncertainty? How do we communicate it to each other within the hospital? How do we communicate it to patients and families? And how do we also communicate this process to a larger audience as science communicators and public health communicators to help dispel that really common notion of you either have a diagnosis or you don't. It's just straightforward. You just need that house MD to figure it all out. And of course, as you mentioned too, Susan, many of us in healthcare, we have those healthcare experiences as well, navigating uncertainty as patients and family members. And I've been with a family member who took a long time to get a diagnosis and a lot of uncertainty along the way, needed a high risk biopsy to really come to the diagnosis before finding a presumptive diagnosis or a working diagnosis and then starting a treatment plan. And so I've been in the shoes of that family member receiving that, well, it's not this, it could be this. And that just spurred me even more to work on this topic.
Those are wonderful examples. And I think you both have touched on, I think, a very important issue about the importance of educating the people that we care for that House is not a real show. I mean, he's not a real doctor, and things are rarely that straightforward. And how do we change that paradigm that I think a lot of us have about you either have the answer or you don't. And then it's very unsettling when you learn, oh, it's a little different from that. So, Dmitri, I would love for you to touch on the work that you're doing about clinical guidelines. And when they don't offer clear answers, how can clinicians work to support patients' autonomy and shared decision-making when things are gray, and things are often gray?
Yeah, no, another great question. I think I touched upon some of this in my previous comment, but when guidelines don't provide clear answers, I think the key is transparency, right? Clinicians have the opportunity to clarify their role, share their reasoning process, which doesn't always happen, and explain the plan relative to the patient situation in that moment. For example, in the emergency department, which is essentially where I practice, this may look like being transparent on the nature of the workup and the nature of the thinking that is taking place in the clinician and then the teams that are taking care of patients, where the team might be looking for specific, immediately threatening conditions that must be ruled out first before we can move on thinking about what other conditions need to be ruled in fact, like what is going on. So that includes naming the conditions of interest that are being investigated. For example, what still requires consideration? Where did this diagnostic journey end today, and how is it going to continue tomorrow? And how the available information that we have together is being synthesized to guide you during that journey. So instead of hiding behind lab values or diagnostic test results, I think clinicians can recap what those results mean in the context of what's going on with them subjectively and invite those patients into the decision-making process. Right? I feel that this would respect their autonomy. I feel that this would engage them in decision-making. I think this would support a collaborative dialogue. And I think this would really eliminate one of the barriers to care that has been impeding trust.
That's wonderful. I mean, you're making me think it'd be great to have an infographic for patients and families that kind of explains everything you just said. So Lakshmi, tell me a little bit about your own experiences with communication and when transparency about uncertainty has actually helped build trust with someone you were caring for.
That's exactly right, Susan. That one of the favorite myths that I love to dispel or myth bust is that acknowledging uncertainty explicitly, just talking about it, actually can build trust rather than erode it. And there are studies both in adult medicine and in pediatric medicine that support this, that when clinicians say, as Dmitri used that word and use that word, transparency, when clinicians explicitly and transparently communicate, this is what we know. This is what we don't know, and we're trying to find out. And then the key next step is not just abandoning someone and saying, this is what we know, this is what we don't know, but actually sharing with them how we're going to walk alongside you throughout this diagnostic process, throughout this journey. What are our next steps? And we're going to kind of iteratively, repeatedly circle back with patients and families to say, hey, we've ruled out, we've excluded aortic dissection, a big tear in the large blood vessel in your chest. We're still waiting on some test results that will make us confirm or dispel if there might be a mini heart attack or something like that. Using that kind of language of, this is what we've taken off the table, this is what we're still considering, this is what we're trying to do next, and standing by that patient and family's side to say, hey, we're not abandoning you in this uncertainty. We're going to actually walk with you. We're going to circle back step by step to share with you what we know and what we don't know. And I often tell patients, as I did just last week in the intensive care unit, I told patients and families, this is what we know, this is what we don't know, this is what we're going to do next. And we're going to keep updating you throughout this time that we have together. And we're going to share with you, even if it's bad news, or good news, we're going to share with you the truth. And whatever it is, we will help get through those next steps together. We will give you resources to support you. We're here for you. And I think that helps us rebuild that trust, both, again, in the intensive care unit, in the emergency department, in our outpatient clinic. It's really that intentionally bringing the patient and family into the team as part of the diagnostic process and diagnostic journey together.
And Lekshmi, I'm going to ask you to stay with us for a minute. Can you tell us a little bit about concrete examples where you've done this with the patient or family and it's really enhanced your collaboration and your relationship with them and what that felt like, how they responded?
Absolutely. Happy to share both an outpatient and an inpatient example. On the outpatient side, early on in the COVID pandemic, I had collaborated with other colleagues to start a clinic for patients who had persistent symptoms after COVID. What we now know is long COVID or post-acute sequelae of coronavirus. And these type of conversations just came up all the time, and they continue to come up all the time, especially when you have this new disease or diagnosis or process that the whole scientific community is trying to understand in real time. And so, a lot of times people will ask, are these symptoms related to COVID? Why did this happen to me? Could this be related? Could this not be related? And it often it's not a simple black and white answer to that complex question. Often we're trying to figure it out. We're trying to say, hey, COVID could be at play here. And I also want to make sure there's not, a hidden lung issue or heart issue or neurological issue that actually accounts for these symptoms as well. And so we're going to do a very thoughtful, pragmatic, and systematic approach to that testing to help us navigate this uncertainty really concretely. And then we'll update you throughout and keep you posted. And I think that helps people know that you're on their team, you're working towards things, that a negative test result does not just mean case closed. And then similarly, in the intensive care unit, sometimes we have patients with, either respiratory failure or sepsis. And sometimes we can know the exact bug, right? COVID caused the respiratory failure, or E. coli caused the sepsis. And sometimes just with the tools that we have, even with our ability to sequence folks' entire genome, sometimes you don't have that exact microbe. And of course, we all wish we had that. I often tell patients, I wish we had that piece of paper, the Star Trek machine, where it would tell us exactly what's the bug, what's the cause, what's the name. And we often don't in the real world. And talking to patients and families in the intensive care unit to say, hey, we don't know exactly what bug may have caused this respiratory failure or sepsis. And we're going to still treat you. This is what we're doing to treat that very thoroughly and thoughtfully. And this is how we're going to move forward, even though we don't have that piece of paper with the name of a specific bug on it. I hope that helps clarify.
Yeah, and patients, you've had experiences where patients and families respond positively to that kind of communication.
Definitely. And it's not just me, it's also the scientific literature that shows that it works in pediatrics, it works in the emergency department, works in adult medicine, where just explicitly acknowledging that uncertainty can help more than it hurts.
Yeah. And Dmitri, what about you? Can you share some specific examples of when this has really enhanced your partnership with patients or a family you were caring for?
Yeah, absolutely. And I mean, it's really hard to forget COVID and the impact that COVID had in all of this. But I can just pick something from just a couple of weeks ago that stands out of a patient who came into the emergency department with symptoms that ultimately, sadly, revealed a new underlying malignancy. And in the acute care setting, obviously, we can answer specific questions about prognosis. And that uncertainty was palpable for everyone, for the patient, for the family. And just like we've been hearing already during the first half of this conversation, we focused on we did not know, right? Like the clinical priorities, what were we looking for? How do we find this? What led us to identify this? So that's pretty concrete to understand. But even then, even after being steeped in this uncertainty conversation for quite some time, what really stood out in that moment, that recent moment, was how that uncertainty is communicated not only to patients and their families, but within the interprofessional care team. Right. So there's a nurse, that's a nursing team that's taking care of the patients, that's interacting with the patients when I'm not there, answering family questions, fielding phone calls. And it's essential that we are all aligned, right? So that my nursing
Yes.
colleagues and I had to be aligned in how we frame that situation. How do we acknowledge the limitations of what we say? Are we saying the same thing? Are we supporting one another? Or are we sending off different signals that further confuse the patient? Deciding together how to best convey the news and ensuring that those messages, again, are consistent. And I truly believe that it's that alignment between all members that interface with the patient, that within the care team, that allows the patient to feel supported and can bolster that support and that trust. I think it just underscores that the whole team is going to grapple with uncertainty. It's not just frontline clinicians or the individuals that are patient facing, it's everyone. And when it's acknowledged openly, when it's communicated, when it's debriefed, when it comes up on rounds, when there are transitions in care, I think being explicit about it can not only build patient trust, but also build team cohesion.
Yeah, and I think what you just said is absolutely critical, because when you hear one thing from the attending, one thing from the resident, sometimes one thing from the housekeeper who's been hearing people talk about your care, it is very disconcerting as a patient or family member. And that clear team communication is just so important on every level for quality and good clinical care. So, at least in my opinion. But so, Dmitri, I'm going to ask you to tell us a little bit about the work you're doing with trainees and students when they first encounter complexity and uncertainty.
No, thank you for this question. I love this area because this is a lot of our research kind of focuses on that transition from preclinical to clinical. So I think when students first encounter that complexity, that uncertainty in clinical practice, like finishing their second year of coursework in the classroom and moving into their clerkship year, that immersion can be very jarring. It can be traumatic. It can have an impact on them. They can sustain trauma from it, especially if there's not a support system to check in with them. For example, a trauma might resurrect some of their own trauma that they lived.
Yes.
So they what happens is they move from this really controlled laboratories, right? These highly controlled, very structured environments, right, into learning environments, clinical learning and working environments that are unpredictable, that are complex themselves, that are part of this larger system with multiple moving parts, and sometimes, depending on where we work, even chaotic. So unless that psychological safety is present, and I really mean that, not just sort of say, yeah, this is a safe space, but truly modeled, right? Where learners feel that it's acceptable to say, I don't know, or more importantly, I need help here, or I'm struggling, to not let those cries get unnoticed, right? And if that safety net, if that culture isn't there, isn't modeled, if it doesn't come top down, they can struggle to thrive. And unfortunately, very, very often, that level of vulnerability, for example, from clinicians, from senior nurses, is rarely modeled for our students. So kind of thinking about this and thinking about these gaps, I think there are strategies that Lakshmi and I have thought about as educators that we can put into place to really scaffold that psychological safety to help learners manage that discomfort that comes with this transition. I think faculty behaviors are critical, faculty and professional development, right? The simple modeling of not knowing their thought process, right? Okay, I don't know what's going on here, but let me tell you how I'm making sense of things. Creating structured pauses, right? Well, let's not go to closure here. Let's think about this. Let's revisit this. And then what's been really fun is embedding a lot of this uncertainty training into our curriculum in the medical school. So, for example, designing cases or simulations that don't have a perfect ending, that are messy, and that end very messy. As educators, we love to tie things up with a bow to sort of say, yes, this is long thoracic nerve injury, and that's causing the scapula thing that we're seeing, and it's done, and we've done that. Check, we've covered that. And it's a little bit jarring for educators themselves to embrace this level of messiness, but we need to try that and find pockets for that. And the last thing I just want to say, this is not all new, right? The humanities for decades have really been offering us tools to help us as clinicians. And I think there are clinicians, as Lakshmi just shared, like visual thinking strategies, right? To embed how we look and how we communicate what we see, and being very objective and not going up that ladder of inference. Narrative reflections, spaces for open dialogue between students and faculty to hear that model behavior, maybe in safe spaces for faculty members themselves, where they're not in this clinical environment where they too might feel unsafe. So I think there are a lot of opportunities. And this one last thing, just to highlight, I'm not implying that these interventions will make students comfortable with uncertainty. And that's okay, because that's not really the overarching goal, right? Sometimes it's impossible to change their preference and how they take in the world in just 4 years. But if we can get them to recognize what they are uncertain about, are they able to appraise it, right? And then are they able to consult a toolbox of strategies that can either help them problem solve, or that can help them communicate that uncertainty, to collaborate with their team, to openly embrace it, to essentially themselves change the culture so that others downstream can share that. I think that's a shift that would be wonderful. A shift from fearing uncertainty to one of just calling it out, being explicit, and working through it productively. I think that is a key for us as educators.
I totally agree, but I also think that is a massive culture change in medicine. I was the educational director for the Duke PA program for several years, and thinking back to how we supported students that said, I don't know, where they thought, if I utter those words, I'll be out of here. And that's a whole culture of psychological safety with everyone on the care team, I think, that's really important. So I guess, Lekshmi, I'd love to hear a little bit about the module that you all are working on and how it addresses some of these issues. And we've also got some questions about how trauma-informed care and understanding that, I think, both with our clinicians and students and also with our patients. If you could maybe speak to that, and Dmitri, I'll give you a chance to speak to that as well.
Absolutely. So a quick word on this module that the link is just dropped into chat. Thank you, Catherine, is because Dmitri and I and our amazing colleague, Dr. Mary Dom, worked together because we were really passionate about educating trainees, clinicians, and the general public about all these concepts, as Dmitri said, kind of acknowledging uncertainty, defining it. How do you communicate it to patients and families? How do you communicate it to each other within teams? What does it mean to say that people might have different natural tolerances for uncertainty? That's just kind of built in to how we navigate the world, and how can we integrate all those experiences together to give these complex, really lofty concepts into more practical, real-world tips and tools for the everyday clinician or patient and family member. We developed this module. We're really grateful to the ABIM Foundation and the amazing funding partners to help support the development of this module. The cool thing about this module is that it not only is pragmatic and self-paced, practical, it's also very bite-sized. It provides really evidence-based strategies, not just for communication, but it's actually an evidence-based educational meta strategy on how we built it. It's not just a long PowerPoint that you have to click through that drones on and on. It's really interactive, where you'll be asked to engage in these sort of mini simulations or practice sessions, just as Dmitri does with his trainees and students, you'll be able to kind of experience that on a smaller scale with the module, and it's freely accessible. So we're really excited to unveil this. Shifting gears a little bit. Oh, go ahead.
I was just going to ask, could you give an example, just a short example of one of the resources or one of the strategies that's embedded there?
Yes. So two quick examples I'll share. One are when you talk about a prioritized differential diagnosis. So it will take you through the strategies of communicating within healthcare teams, how to identify a prioritized differential diagnosis. I think early or novice trainees, often they come and they say, the differential diagnosis for chest pain is heart attack, acid reflux, and everything in between. And how to actually get people to communicate and convey, you know, in this situation, I'm most worried about heart attack or aortic dissection. But actually, I think that the most likely diagnosis in this case is acid reflux, and here's why. But my can't miss diagnosis is this heart attack that we need to make sure he does not have that because he has risk factors. So it will talk you through, the module will talk you through that, how to make a prioritized working differential diagnosis. Another part that the module talks about is part of our research on transitions of care is about how do you transition care from a sick intensive care unit patient to a patient who's kind of graduating from intensive care to a regular hospital ward room. And again, they are not necessarily cured at that moment. They're just not critically ill anymore. And often that diagnostic uncertainty that's still at play will follow the patient across these care contexts, different clinicians, different nurses, different teams taking care of them. So we talk about a structured tool, a diagnostic pause called the ICU Pause tool, which is a communication framework to talk about uncertainty within the healthcare team. There are also tools to explore your own comfort or discomfort with uncertainty, which is really cool. There are also tools about how to communicate about discharging patients in the context of uncertainty, and all these mini practice opportunities. Anything to add, Dmitri, on highlights of the module?
No, I think you covered all of them. I think the ICU Pause is a really great tool, the uncertainty communication checklist that really scaffolds the conversation for a clinician who's about to discharge a patient with diagnostic uncertainty in that moment where there's not a lot of time to think. Having a script there, a tool there that has been patient informed and developed by patients with my colleague, Dr. Kristen Rising. So I think that's a tool. And another tool, and she's not here now to speak to some of this work, is the work of Dr. Mary Dam at Deakin University in Australia, who in her work has examined the linguistics of communicating uncertainty, right from the word choices to the kind of phrases that clinicians use. Like, well, this could be, could. Are we hedging? This may be. Or are we just not, are we getting to what we want to say and that we don't have a diagnosis but never really mention, I don't know what's going on with you? So if she studied this, and it's really great to have that linguistic approach built into the module just to get individuals to be a little bit more reflective about their own communication styles. Is it explicit? Is it clear? Is there an opportunity for improvement? So it's really taking research, and we love knowledge translation, right? We do this great research, we know what to do, but it sort of stays there and doesn't get implemented. And what this module has been able to do is it allowed the three of us to approach knowledge translation, to kind of take the research, the best practices that we've identified in our work that's been vetted by our peers and our professional societies, and to really introduce them to clinicians. And one last thing that I think is really special, I'm sorry if I'm going over, but because it's outward facing, it's not just available to clinicians. And I think the community, patients, individuals can sort of examine that and see that. And I think that's really a rich opportunity for us to build trust, right? It's there, it's explicit, we're talking about it. This is how we're learning about it. This is what you should look out for. So I think that outwardly facing approach to this module is special.
Susan, you're muted.
Yeah, sorry.
That's okay.
Yeah. So I think
Susan, if we might come back to your amazing second part of your question that we didn't get to address yet, because we were so excited. Yeah, absolutely. Yeah. Because I do think
But
that.
I do want to, I'm just going to write something down. I don't want to forget it. Go ahead.
Yes, no, I just don't want to gloss over that really important concept that you brought up, and that one of our questioners in the chat brought up, about this concept of trauma, and also the link between trauma and mistrust and uncertainty and communication, and how do we bring all those together. I think first and foremost, we have to really acknowledge that in the house of medicine, we have done harm before. Historically, we have contributed to breaches of trust by large swaths of our population, our community, who have been wronged, frankly. And our challenge is to balance, our honest, empathetic communication with the limitations of medical knowledge. Like I said, we don't have the magic paper for everything, and really be cognizant about where our patients are coming from and what they've experienced. They might have experienced harm by the healthcare system previously. They might have experienced trauma in the healthcare environment previously. And that trust might have been eroded from before. And our role is that we have to be really mindful of all the different lenses and experiences that people, clinicians, patients, and families alike, are bringing to the healthcare encounter, and thoughtfully and empathetically work to rebuild that trust that has often been disrupted or destroyed or eroded. And we feel strongly that communicating honestly, empathetically, transparently, talking about uncertainty is a way to rebuild trust in people who've had healthcare trauma or who've been harmed by the healthcare system before. And just acknowledging that, I just wanted to say that explicitly.
Yeah, no. Go ahead, Dmitri.
And if I could just briefly add, agree with everything 1,000%. And it's really inspiring to see that a lot of the literature and the interventions that we've adopted from trauma-informed care are making their way into curricula, such that there's a movement on trauma-informed medical education. Really great perspective piece that came out in academic medicine a few years ago. And what we're seeing now in the literature are testimonials and case studies and exemplars of how we can do that. And that is something that we've been trying to do in our curriculum at Jefferson. Basically, from everything that Lakshmi said, how can we be more transparent? How can we be more patient-centered, right? Bring those tools in. At the same time, being mindful of the milieu in which our students are learning, and more importantly, the milieu that they'll be practicing in the short term and in the long term. So it's been really great to sort of see this new area of study, trauma-informed medical education, come up. And I think that gives us some hope that there's an opportunity for improvement in our programming.
I think it does, and I think it's also, you mentioned this earlier, we have to think about where the students come from and where the faculty come from and how their own experiences influence their interactions with patients, because sometimes those run into each other in pretty spectacularly negative ways that we have to address. A question has come in that I think is a very interesting perspective on this, and I suspect it's a type of uncertainty that is growing more and more common, and that is for the clinician who is, and this is from someone who's a hospitalist, who has her own level of uncertainty when she's discharging someone that is going to need other types of testing and care in the ambulatory setting, about will it happen correctly, how does that, can you all say a little bit about how the modules and the educational work you're doing addresses some of that, or may help people with some of that kind of uncertainty? That's more about, I think, sort of access than actually,
Totally.
and connected to diagnosis perhaps and treatment.
Absolutely. And Dr. Sood, I definitely resonate with this question. I work on the hospital medicine wards as well. And so I frequently encounter this. It's yet another high-risk care transition, right? So I talked about the ICU to ward care transition and the importance of explicit communication about uncertainty in ICU to ward. And I think similarly, when you're moving from the wards to discharge, that's another high-risk transition, or emergency department to discharge. That's another high-risk transition where we're going to say exactly what we want in an ideal world, right? Ideally, we want the person to get the outpatient MRI, to follow up this tiny liver lesion. We need that outpatient MRI to really look at that in more detail. And we put in that outpatient referral to the liver specialist. And in the real world, on the clinic side, sometimes you prep the entire visit and then the patient has a transportation issue where they can't come to clinic. They have barriers. They have a family emergency. They can't come to clinic. They have an insurance prior authorization issue where they can't access that medication that you expertly got for them on discharge. And I think that that's exactly what you're talking about, Dr. Sood, when the real world of medicine, as imperfect as it is, kind of collides with the best laid plans as well. And so I often try, and Dimitri's done a lot of great work with the uncertainty communication checklist that I'll turn to him next to talk about as one way to talk about that very concretely. The way that I approach it in the hospital is I try to be really explicit, and again, over communicating is better than under communicating in these situations of, I've placed a referral to hepatology clinic, liver clinic. They should call you within 7 days. If you don't hear from them, please call this phone number. I've put an order in for an MRI of the liver to follow this up. This is actually urgent, must be done within 30 days. If you're having trouble with getting this approved or anything like that, definitely giving them a linkage point, whether that's the PCP, whether that's a post-discharge clinic, but saying, hey, if you encounter barriers, this is your point person. This is your amazing primary care provider looking at the whole picture in totality after discharge, or this is your post-discharge navigator who will give you a call to make sure from a systems level that there's no things that get fallen through the cracks. So I try to be really explicit about what are the things in the healthcare system that we're keeping them connected, their primary care provider, a post-discharge phone call, or a navigator, patient and their family, and also giving that patient and family those tools too to say, hey, this is really clearly kind of our collective next steps, our collective homework, and we're going to work hard to help this happen, this workup happen. And if it doesn't happen, here's how we troubleshoot that. So that kind of takes away some of that anticipatory anxiety and troubleshoots. And yeah, when a medication doesn't get approved, I often will empathize with that frustration of, gosh, this sucks. I agree. I'm sorry, this is not covered for you. This medication that we know is proven to help you in these situations. I am so frustrated too. I share your frustration that this is not covered. Let me work with our office to try to submit an appeal letter to get that covered from you. Or, sometimes if you go to the company's website, they have a coupon system. Let's look at that for you. Let's have our team pharmacist call you to see if there's any coupons that you can navigate. Let's have our social worker work with you to see if you can get a supplemental insurance or enroll in your state's Medicaid as well. So kind of giving people as concrete tools as possible to help them navigate our morass of a healthcare system.
Great. Thank you. Dmitri, do you want to say anything about the checklist? Yeah.
So, and along the lines of support, I think supporting clinicians and trainees. So health system science pushed really by the AMA to get medical schools to address how systems impact care has really gotten us to a point where we can be very explicit on how social and structural determinants of health are going to impact the care plans that we've thought so hard about and try to implement. So what does that mean in a practical setting? Well, it's really given an opportunity for members of the care team, particularly students, to conduct social determinants of health screening. So screening of patients that come into our care system, whether in the ED or in the clinic. Our students are there, they're conducting screening, and they're flagging those patients that will likely have some sort of hurdle to overcome in order to really enact that amazing treatment plan. So it's hearing your question, Dr. Sood, and hearing the reaction and the comments from Lakshmi is great for us. And then I'm trying to think, okay, well, how is this codified into something that involves our trainees that is both educational and sustainable? And that has really been codified in our curriculum by getting our students to really understand health systems and to provide them a screening tool to really identify those patients that are at risk.
I think one other thing to emphasize, Dmitri works, we can talk about this all day. Dmitri works in the emergency department and I work in the intensive care unit. Sometimes people colloquially call us, downstairs and upstairs, but it's highly dependent on geography of your hospital. But one key point that I convey to trainees all the time is no matter what the patient and family says, is to not badmouth other healthcare professionals. to really give that, again, psychological safety that we're all on the same team. To not say, oh my gosh, I can't believe your primary care provider missed this, or I can't believe the ER missed this. To really ally with the whole healthcare team to say, hey, we have new information now that we're looking at. We're going to look at this holistically. These are our best steps forward. And to really be all on the same page as the healthcare team, both with colleagues across departments and with our colleagues across professions, as we previously talked about, our amazing nursing staff, respiratory care practitioners, to just really all be on the same page when conveying that uncertainty to patients and families, because it can be really damaging when people unintentionally or intentionally badmouth other providers at different points in the healthcare journey, whether that was the primary care doctor or the emergency department or the other specialist they saw before you saw me, etc.
Thank you for sharing that.
Yes, I mean, we actually, in the work I do around improving the patient's experience of care, we often spend a lot of time training everyone that has any contact with the patient about how you transfer trust. When you're sending someone from an inpatient unit down to get imaging, you don't say, you're going down to get an MRI, we may see you in a month. That does not engender confidence. Or, we're sending you to the lab. They have no idea what they're doing. People make these statements. Sometimes they think it's humor, but it's very, very unsettling to people. And I think it's so important for us to keep in mind that we're building trust, not diminishing it. I'll get off my soapbox. But so, Dmitri, we just got a couple more minutes before we're going to open it up to questions from everyone. But I'd like you to say a little bit about your thinking about preparing future clinicians beyond training and how we can embed uncertainty as a core competency throughout a clinician's career, not just during their formal training.
No, thank you so much for that question. I think I touch upon some of this, so I'll just talk about our own work at Jefferson in Philadelphia, which has really been inspired by graduate medical education. Right, I mentioned that we first observed how residents struggle to communicate diagnostic uncertainty, and from that, it led to our research that uncovered best practices, validated checklists. It led to simulations and training tools, all of which are on our Center for Connected Care website, open, free access if you wanted to look at them. But in the spirit of knowledge translation, we realized that we couldn't wait until residency to incorporate this training. That just can't happen. That's like a no-go, which is why and I know you asked about downstream, but we first thought about codifying this upstream in our UME program. So as formal training, not extracurricular, not co-curricular, but curricular, so that students can actually embrace uncertainty as early as day one. To make uncertainty or navigating, problem solving, communicate uncertainty, all of that a true competency, I think we need both a ground up and a top down approach. Right from the ground up, obviously, undergraduate medical education, nursing education, GME, fantastic. And from the top down, we need continuing education for our practicing clinicians, and we need our professional boards and we need our professional societies and organizations to really recognize this, to prioritize this, to find ways that this can be assessed and that it can be reinforced as a skill. And I think that's where a lot of the work still needs to be done to advance this. So I think the key thing here is that this work should not be seen as extra credit or extracurricular, right? It's a core competency. It should span the continuum of health professions education, and it should really span the entire career arc, right, from student to seasoned practitioner. So I think there's a lot of work for us to do collectively.
I do too. I think you've got a very bright future in your careers focusing on this, because this is a perpetual issue for all of us in medicine and in life. So we're getting close to the end of our time. I'm just going to ask each one of you to share 2 or 3 practical strategies that people can use immediately after hearing this today. So, Lekshmi, want to go first?
Sure. I think, Susan, you phrased it well with really framing this conversation very early on about building trust. And I would say that is the key point, is to lead with empathy and come from a place to try to gain trust. And if you're in a situation with diagnostic uncertainty, how that looks like is talking about stating what you know and what you don't know and what you're doing next, very clearly and explicitly, pausing frequently to check in, to get clarification questions, to answer those clarification questions. And again, I think that most important piece is people often are comfortable with saying what they know. People are less comfortable with saying what they don't know, and then actually having that link between what you know, what you don't know, and how you're going to walk with that patient and family through the next steps together in this diagnostic journey to get clarity. And I would add, to manage symptoms along the way. A lot of times people get almost, I don't want to use the word fixated, but people anchor almost prematurely on the diagnostic process and the diagnostic reasoning. We don't have a diagnosis. We don't know if this is COVID related or not. At the same time, we want to treat people's symptoms and how they're feeling now, right? So I think that's another thing that in medical education, the culture of medical education, we often think about diagnosis and management really separately. Whereas in the real world, in clinical practice, we're saying, hey, you're having chest pain or you're having shortness of breath. Let's figure this out. And at the same time, in parallel and tandem, this is what we're going to do to treat your symptoms, to manage your symptoms, to help that chest pain or help that shortness of breath feel better now while we're sorting out the diagnostic journey. I think that that is another key step.
And I think that actually really makes people understand they've been heard, which is incredibly important. So, Dmitri, what are your 2 or 3 pieces of wisdom? Because we're almost at the end of our time.
Now, great points from Lakshmi. I'm going to say normalizing uncertainty with patients, right?
Thank you.
Frame uncertainty as common. It's not an exception, right? Again, going back to the emergency department, about a third of our patients who are discharged home leave with a symptom-based diagnosis. They come to the ED with abdominal pain. That's their chief complaint. They get worked up, labs, exam, history, radiographic imaging, and they leave with a symptom-based diagnosis, essentially a proxy for diagnostic uncertainty. And this happens a third of the time. So really being explicit that this is normal and that's okay, and this is what we're going to do. And I think the next thing for me is really inviting support. And by that, I mean inviting patient support, asking patients who else they would like to be physically present, whether on the phone or in the room, when these difficult conversations around uncertainty and next steps and planning come up, right? Because when that patient leaves, they're going to sit and marinate in everything. And having someone else there who knows that conversation that they can have a dialogue with, that can maybe fill them in on pieces of information that they didn't hear because they were just so overcome with this, catecholamine surge of just dealing with not knowing and having that uncertainty. I think bringing in family, loved ones, partners, just fosters that trust. Like, let's talk about this. I'm not hiding anything. So those are my 2 things.
That is wonderful. I think we've maybe just got a minute or 2 left, but I am just going to, someone put in the chat earlier today, sort of made a comment and a question about how you all and whether you all have learned from your palliative care colleagues who are dealing with uncertainty pretty much all the time in their interactions with patients and families. And can you say a little bit about anything you might have learned from that specialty that has informed your work and how to communicate about uncertainty? Because I think that's where I've learned so much.
Absolutely.
Yeah.
Our hospice and palliative care medicine colleagues are amazing. They're truly masterful at navigating and communicating uncertainty. And a lot of the palliative care and serious illness communication literature really focuses on concepts in communication that are very much aligned with uncertainty communication. And, both Dmitri and I definitely explicitly acknowledge that when we write about these topics as well, that a lot of these concepts that we're talking about have deep roots in that hospice and palliative medicine literature about talking about uncertainty, anchoring it first in that patient-centered approach. Who is this individual as a person? What are their hopes and dreams? What are their values? Really leading from who is the person? What are they like, or what were they like in the past? And these concepts that guide us during serious illness communication, during family meetings, I use those pearls from my palliative care colleagues all the time when I'm approaching a high stakes family meeting in the intensive care unit. And I know that not only am I breaking bad news, which is again a whole other palliative care sphere of excellence and literature, and I'm layering this additional level of complexity on it. I'm breaking bad news, and there's this diagnostic uncertainty in play. So it's kind of that double whammy of difficulty. And we have a lot to learn from our palliative medicine colleagues, and they are great communication experts. Of course, I'll shout out Vital Talk as a wonderful palliative care resource. That's a wonderful educational tool. We train our fellows, our residents in Vital Talk strategies as a great place to go for communication skills training about serious illness, but it's very applicable to uncertainty in many settings.
Yeah, yeah. And what does the patient think is going on? What do they understand? Dmitri, anything you want to say about that? And then I think we're going to turn it back to Randall.
Sure. I'll be fully transparent. It's been learning from my ICU colleagues, particularly one colleague who put together a structured pause called the ICU Pause, Dr. Santhosh, in codifying the transition from discharging, or rather admitting patients in the hospital system from the ED to the floor, or the ED to the ICU, and finding ways to build this into the medical record, right? To sort of say, yes, there is diagnostic uncertainty, like, please be aware of premature closure. Yes, we needed to do this to admit the patient, et cetera, ... We know how the HIT curriculum dictates how things happen. But to really be explicit and find ways to do that, and the ICU Pause, again, from my ICU colleague, has been a really great structured approach to do that in ways that no one really thought the medical record could help you in those instances. So like an SBAR, but really centered on uncertainty. So that's my shout out to Dr. Santhosh.
That sounds wonderful, and I'll remember it because it sounds like a new line dance.
I love that. Now we got to make that.
So, Randall, I'm going to turn this back to you. Thank you so much for such an incredibly rich discussion today, and for the incredible work you're doing. We need thousands of you. So, Randall.
Thank you.
Thank you so much, Susan, Dmitri, Lekshmi. This was such a great and informative conversation. I wrote down a few things that kind of stood out to me, and around like transparency and acknowledging uncertainty and how that can build trust. And Lekshmi, there was something that you mentioned around like, we're going to walk alongside you in this journey. And I think if a physician said that to me, I'd be like, I'm in good hands. And so I think that were two of the things that had stood out to me today. And I also just want to encourage people to go to the module and see it. And Catherine's going to put that link in the chat, and go ahead, and it's self-paced. So go ahead and try your the different modules and learn more about uncertainty. And then a few logistics in terms of the recording. We'll send it out to you after we have it, and you can visit buildingtrust.org to register for our future conversations. But I really, really just want to say thank you again to Susan, Lekshmi, and Dmitri for what was such a really wonderful and generative conversation today.
And I just want to thank you all again for the work you're doing. It's so important. So thank you.